would it be advisable to start both together, the dual antiplatelets and warfarin, or just warfarin to begin with? But I think you made your point that probably dual antiplatelets were not required.
Not recommended for these ladies.
See, one of the aspects that the neurosurgeon concentrates in these cases is absolute hemostasis, because the spine is a very compact space. It is susceptible to buildup of pressure whenever there is a clot. So they do these surgeries under an operative microscope. They ensure that the field is absolutely dry before they close. But it is interesting to note that to maintain an INR of 1.5, only 40% of vitamin K dependent factors, which is 2, 7, 9 and 10, are required in the circulation. So we don't need to be looking at 80% or 100%. If you have 40% of these factors in circulation, that is good enough to maintain an INR of 1.5. So thank you. With that, we end discussion on this case. In the interest of time, we quickly move on to the next patient, which is a patient with coronary artery disease coming in for a hemiarthroplasty of the hip.
Now we call upon the stage Dr. Chaya, cardiac anesthetist, Aster Ramesh Hospital.
Good morning, everyone. So I'm going to present about a 70-year-old male who presented with history of fall at home, pain and swelling in the left hip joint, and was admitted for left-sided hemiarthroplasty. So relevant medical history was patient had anterior wall MI in 2005 with PCI to LAD. He had anterior wall reinfarction in 2024 and was in AF with control rate and moderate LV systolic dysfunction since then. And patient also had CKD since 2015 and was on treatment. He was a known hypertensive, non-diabetic and non-smoker. So blood investigations showed HP of 9.2, serum creatinine of 2.6, blood urea nitrogen of 46, and potassium, which was initially 5.5 milliequivalents per liter, was corrected with K-bind and insulin dextrose infusion to 3.6 milliequivalents per liter. Ultrasound abdomen showed bilateral small kidneys with no evidence of hydronephrosis or ascites. Echocardiogram showed an LVEF of 35% with regional wall motion abnormalities. Medication history. Patient was on Emidaron 100 mg BD, clinidipine 10 mg OD, diuretics, statins, and dual antiplatelets. Clopidogrel was withheld 5 days before surgery and was bridged with heparin, unfractionated heparin 5000 units, 8th hourly. So in view of and spinal anesthesia was given in L3, L4 space with 12.5 mg of 0.5% bupivacaine and 25 micrograms of fentanyl. Intra-op vitals were within normal limits. The surgery lasted 2 hours and post-op heparin was restarted post-op 4 hours after surgery. Post-op analgesia was maintained with epidural 0.125% bupivacaine infusion for 48 hours. Epidural catheter was removed on the second post-op day and after 6 hours after last heparin dose, and heparin was given 2 hours after removal of catheter. So patient had an uneventful recovery and was discharged on 5th post-op day.
Thank you very much for this presentation. This brings back several memories in care hospitals when we started. there would always be this discussion between the cardiologists and the orthopedic surgeons about the timing of these patients for surgery. Hemiarthroplasty of the hip is done for a hip fracture, as we all know, and 90% of hip fractures occur in patients above the age of 65 years. And no other fracture has such a strong association with mortality as a hip fracture. The 30-day mortality is as much as 7%, and the mortality at 365 days is as much as 23%, which means that 1 in 4 patients who've had a hip fracture will not be there at the end of 1 year. And these are UK statistics. I mean, in our country, the statistics could be a lot worse. And we must remember that patients above 70 years of age have more than 5 comorbidities, including repeated falls or lip vision loss or hearing loss, and most of these patients take at least 5 medications. So when we take up this patient for admission, sir, would you agree that the aim would be to operate on these patients within 48 hours so that we don't have certain complications such as bed sores, urinary infections, depression, and so on?
As early as possible is better.
Yes.
To avoid.
So the dictum as per the AAGBI guidelines would be to try and bring the patient onto operating table within 48 hours. Now there is a phase which we call prehabilitation before the surgery, wherein we give attention to what meds to continue, what to stop, nutrition, hydration, psychological counseling, and another important aspect of this is treatment of acute pain. So when there is a hip fracture, we know that there is disruption of periosteum, and this causes acute pain. Dr. Bheem, would you advise any on-arrival block in the emergency room for these patients to control or treat this pain?
Yeah, good morning everyone. Yeah, that's rightly said, TVS. On-arrival blocks is the dictum of the day. Not only for this type of fractures, for any type of fracture, on-arrival block is the thing which is to be practiced for all types of trauma. And for this too as well, we can give a femoral block to see that, as well as a sciatic block, to see that the patient is absolutely pain-free, so that other things don't go up. His BP and all will not shoot up.
That is correct, because 60% of the pain comes from the anterior capsule. So if we can do a femoral block or a fascia iliaca block, or these days there's a new block called the pain block, which is the pericapsular nerve group, which targets only the articular branches of the femoral operator and accessory operator nerves. So the ubiquitous availability of ultrasound has made all of these blocks on arrival in the ER by non-anesthetists very possible. Now, between GA and regional anesthesia, is there any preference at all? Do you believe that regional anesthesia is safer than GA in these patients?
Yeah, definitely. Regional anesthesia is much safer than general anesthetic in these type of cases because of the early ambulations and all. So I would, like what the presenter has done, the technique of choice for these type of cases would be a regional anesthesia.
Now, there have been lots of studies between GA and RA, and the final conclusion is that at the end of 365 days, in terms of outcomes, GA and RA is really no different. In the West, they typically tend to do any procedure under GA, so that is why we have this data with us. But I would agree with you that regional anesthesia is definitely safer, especially in reducing the incidence of post-operative cognitive dysfunction, in reducing the blood loss, and in enabling the patient to cooperate with physical therapy in the post-operative period. And sir, do you have any particular preference in terms of anesthesia, or is it important that the patient just doesn't move during the procedure?
Regional is better always.
They gave an epidural for this patient, but is there another option, Dr. Srinivas, besides epidural?
Rightly mentioned, the periarticular block, by putting a catheter, you can give continuously. The being an advantage is the sympathetic block can be minimized. So the early immobilization, whatever the surgeon was initially planned, early rehab, all these things can be done with a peripheral nerve block, putting a catheter in that area with an ultrasound guided.
And my practice has been over the last 10 years. We have done at least 1,000 such patients, wherein we have done lumbar and sacral plexus blocks alone. And the hemodynamic perturbations following these blocks is definitely much lesser than you see with a graded epidural or a spinal. And the anesthesia is limited only to the side of the surgery. And post-op also, these patients are comfortable for about 16 to 18 hours. So thank you very much. Before we move on to the next case, is there any comment or observation from anybody in the audience?
Nice cases, sir. Good morning. I am Dr. Pani, surgical oncologist, Ramesh Hospital. Just want related to the second case where that malignant neural compression. Usually, is that any protocol like, because when we do cytoreductive surgeries for the ovarian cancers or when we add HIPEC, those times the patients will bleed like hell. They will have a chemotherapy. When we are operating, we operate for 7-8 hours. Those times we observe a lot of bleeding will be there and some hypothermia will be there followed by hyperthermia. Coagulation derangements will be there. If I take this kind of case, the same kind of scenario patient with having a ovarian CA, whether doing just PTA, PTT INR with 1.4 INR is okay, or should I do TEG is a mandatory, because whatever I do, because intraoperatively it will bleed a lot. That time my anesthetist will start giving lot of FFP. And same time he will be very concerned about trally also, because patient has to come out, the surgery will be 7-8 hours. It's just like INR 1.4 is sufficient in these kind of cases. I have to deep dive into the tech and correct.
Let me answer your question, sir. INR basically refers only to those patients on anticoagulation with warfarin or esinofumarol. I mean, we don't really need to do INR for all patients. So if a patient is bleeding, I think TEG is very useful. Most hospitals today have TEG, and based on the evaluation of the TEG picture, we can decide whether to give FFP or cryoprecipitate or platelets or even antifibrinolytics such as tranexamic acid. So this discussion will go on. So in the interest of time, I'll stop it here. But yes, INR is not indicated in all patients, especially those who are not on anticoagulation. Yeah. So can we move on to the third case? This
Yes.
is very interesting.
Yes.
A laparoscopic oblique open cholecystectomy.
Now I call upon Dr. Himabindu, cardiac anesthetist at Ramesh Hospital, to present the next case.
Good morning, everyone. Presenting a case of 68-year-old male, came with a complaint of pain abdomen, known diabetic since 20 years, not a known hypertensive. On examination, tenderness was noted in the right hypochondrium. Ultrasound abdomen suggested acute calculus cholecystitis, choroid perforation of the gallbladder, bilateral mild pleural effusion, grade 2 fatty liver. Blood investigations showed total count 14,000, CRP 200. All other blood investigations are within normal limits. Subsequently, patient develops shortness of breath. Tropi is positive and no ST elevations are noted in the ECG. Coronary angiogram was done and it showed left main and triple vessel disease. Injection heparin 5000 units IV 6 hourly was started. Echo showed EF of 50% and grade 1 diastolic dysfunction. Ventricular ectopics were noted during the study. And case was referred to the general surgeon, CT surgeon and discussed with the cardiologist. Cardiologists and CT surgeons advised to go ahead with open goli with high risk for perioperative events. CT surgical team was kept on standby. Injection heparin was stopped 8 hours before surgery and all emergency drugs were kept ready and standard monitoring was connected in OT. IV line secured with 18 gauge cannula. Left radial artery cannulated for continuous blood pressure monitoring. Right IJV cannulated. CVP monitoring was done. NTG infusion was started. After pre-medication with glyco and midas, patient induced with fentanyl, etomidate, vecuronium and intubated with 8.5 endotracheal tube and connected to the ventilator. Maintenance was with O2 and sevoflurane around 0.2 to 0.8%. Intra-op hemodynamics was stable, blood loss was minimal, urine output was adequate. So patient was extubated on table and shifted to ICU. For post-op pain relief, injection fentanyl 50 mics per hour infusion for 24 hours was given and paracetamol SOS. Post-operatively, drains were checked and heparin IV was started 8 hours after surgery and cloplet was started on post-op day 2, soft diet given on post-op day 3, drains removed and discharged on post-op day 5 with ivabradine, metoprolol, cloplet and aspisol. CABG was planned after 3 weeks, so patient got admitted after 3 weeks and CABG was done. Thank you.
Thank you, ma'am, for that presentation. Again, a very, very taxing case, a catch-22 situation here. We have acute abdomen on the one hand. You have a gallbladder which is full of calculi. It is distended, and there is bound to be an impending perforation, which would lead to biliary peritonitis. On the other hand, on admission, we got to know that this patient had a de novo diagnosis of coronary artery disease. One is operative laparotomy / laparoscopy takes precedence. It is an emergency. And CABG, despite the involvement of the left main coronary artery, is pushed into a time-sensitive surgery mode, which is where you can postpone a particular surgery for obvious reasons for a period not exceeding 3 months. Now, in these cases, we go for preoperative risk stratification. So, Srinivas, as per you, would you say that this patient falls in the high-risk category?
Yeah, as per the latest 2024 AHA/ACC guidelines, the class 2B recommendation is this patient should go together because the patient, I don't know how tight the left main is. If a patient who has a left main very tight, going for a non-cardiac surgery, you're putting the patient with a high dangerous zone. And the second point is the patient has already elevated tropi, which means there is an imbalance between the coronary perfusion. And the third point which Madam has told at the beginning itself, there are ectopics. So the conduction abnormalities have started. So we all know that which side we have to choose. Go in the neutral pace. On the same day, if the laparotomy has to be done, then do a emergency CABG on the same day, instead of waiting for 3 days with the patient with the left main tight.
So that is a more point for discussion. But before we proceed with either surgeries, I think it's very, very important in these patients to have a joint counseling of the patient and the family. I mean, this is something Dr. Somaraju always taught us when we had faced such situations. So you would agree that the anesthetist, the general surgeon, the cardiologist, the cardiac surgeon, and critical care physician will sit with the family and preferably do a video counseling?
Definitely, sir. It is a multidisciplinary team approach has to be initiated at the beginning itself. The reason is this patient has multiple problems. It has to be dealt by different people at different levels. So we should give every information what is need to be given to the patient relatives, then discuss and document everything.
So what would your preference be? I mean, in these situations, because time is of essence, would you go for a laparotomy or a laparoscopy? Which would be your preference?
My surgeon wants to put a comment here.
So, laparoscopy is ideal, but the patient is on anticoagulation when they started. Laparoscopy is contraindicated, but the laparotomy is opt in this case so that we are removing the source of toxemia, which helps us in treating naturally the myocardial infarction part. So the regular phenomena protocol what we follow, whenever there is sepsis and myocardial infarction go together, we remove sepsis, importance for that. So always laparotomy when compared to laparoscopy is safe because of anticoagulation. Thank you.
Dr. Beam, in this particular patient, do you think the deleterious effects of pneumoperitoneum during laparoscopy can have a bearing?
Yeah, exactly. The effects of hypercarbia and all will definitely add to the already existing cardiac conditions, the ectopics and all. So ideally, laparotomy would be a better choice compared to laparoscopy.
Again, this is something we can debate on and on. I've worked with so many surgeons who would vouch that laparoscopy, to begin with at least in these situations, would be the best answer. Now, Johan, this coronary angiography proper, which would you prefer?
Yeah, in this case, certainly this patient is obviously the highest risk. He has angina, he has a troponin positive. So this is a case which should go to the cath lab straight away. And as you said very rightly, and some of my colleagues have said, left main disease with an elevated troponin T, I can't imagine anything at higher risk. So I think the angiogram would be the better thing to do, although it would still entail a little bit of anticoagulation to do the angiogram. So that again has to have a consultation with the surgeon, the anesthetist before proceeding. But CABG would be my choice first, followed by even a drainage cholecystotomy, for example, if required on the same day.
That is true. There have been several instances wherein a patient presented for CABG, but the cardiac surgeon refused to operate and told the patient, please go get your non-cardiac problem first addressed and then please come back to us. Now, there is a term in the ACC/AHA guidelines of 2024. It is myocardial injury after non-cardiac surgery, MINS. So how would you conduct surveillance to ensure that myocardial injury after non-cardiac surgery is not either new or ongoing?
Want me to answer? Yeah, that's called as a MINS, myocardial injury after non-cardiac surgery. The latest terminology has been incorporated in 2024. The recommendations are you have to periodically evaluate the progressive rise of the troponin for 6 hours, 12 hours, 24 hours and 48 hours. If it is elevated more than 10 times, it is pathognomic. And you also should check, is there a new onset of RWMA? Apart from the pre-existing RWMA, that means that the patient is going to have some cardiac event. Then you have to immediately address these issues before you take any further action.
Yes, thank you. So, any comment from anybody in the audience on this? All right. So thank you. With that, we end discussion on this. We have exactly about 12 to 14 minutes left for the last case. I request that to be presented by who is presenting the last case? The total knee replacement.
So we have only 3 cases for this.
Oh, you had only 3 surgeries? Okay, I'll just read through the last case. This is a patient who had anterior wall MI. He had a drug-eluting stent placed in 2014. He had another MI in 2021. He had another drug-eluting stent placed in the obtuse marginal 1. And this patient is on carvedilol, rosuvastatin and clopidogrel, ezetimibe, nicorandil, nitroglycerine, torsemide and Vimada, which is a combination of sacubitril and valsartan. And this patient's ejection fraction was 35%. And the orthopedic surgeon told me, this guy is 70 years old, he's come from a village, he can't keep coming back to the theatre. Though his left side is more symptomatic than the right, can I go ahead and do a bilateral total knee replacement in this patient? So how many anesthetists would agree that we can proceed with a bilateral total knee in this patient? I actually put my foot down. I said, no, we will address the symptomatic knee, which is the left side. Because we know that when we do a bilateral, the incidence of DVT and pulmonary embolism is 3 times higher. The incidence of perioperative transfusion requirement is 3 times higher. And the compliance with physical therapy is greatly delayed because the patient does not have a good limb on which to place the weight while starting to walk. So we decided that we will go with a unilateral left-sided total knee replacement. And my choice was to do a low volume spinal. Now you may ask, what is a low volume spinal? In this particular patient, I gave just 1.8 ml of 0.5% hyperbaric bupivacaine, which is 9 milligrams of bupivacaine. And we supplemented this with ultrasound-guided adductor canal and IPAC, which is infiltration between popliteal artery and capsule of knee. Now, I want to ask Johan to enlighten the anesthetists about sacubitril and valsartan, and whether we need to give it on the morning of surgery or withhold it.
The RNA is a combination of 2 drugs, and while it's extremely effective in chronic heart failure, there is a big issue when you're going to give it on the day of surgery because it causes, just like the RAS family, the ACE and R, significant hemodynamic issues, including drop in blood pressure, diuresis. And this could be catastrophic, especially when you're dealing with a patient already having a spinal anesthesia, single or both knees. So despite the effectiveness of this drug, I think it is really wise to hold it on the day of surgery. Make sure the patient is well fluid replete. You can use the NT-proBNP before and a 2D echo. Look at the IVC, look at the NT-proBNP and adjust its volume. Obviously, you will have a CVP line as well. So I think it is really worth not giving the drug, holding it maybe for 24 hours, let the patient stabilize, look for bleeding post-op, and then maybe after 48 hours if the patient is stable, then only do it. So that would be my choice.
And the other thing I wanted to mention is patients these days are on combination drugs. This patient was on Rosuvas Gold, which is a combination of rosuvastatin and clopidogrel. I am sorry to say this, sir. Orthopedic surgeons really don't want to know too much about the medications that the patients are on. They expect the anesthetist to be able to decide what to stop and what to continue. So my advice to all anesthetists is, please look up literature, and if Rosuvas Gold is a combination of rosuvastatin and clopidogrel, please stop clopidogrel 5 days prior, because this is an elective surgery, patient can wait. Is there anything else you would like to add, sir?
Actually, Rosuvas Gold is a combination of 3 drugs. There's aspirin, clopidogrel and rosuvastatin. So it's quite a big mix. So clopidogrel certainly out of the picture 5 days before. But if the person is very high risk, like we saw this patient with LV dysfunction, 2 stents, I think peri-op aspirin shouldn't be an issue, provided the anesthetist and surgeon are all right with it. So statin certainly, aspirin 75 milligrams should be okay, and we can obviously watch for bleeding post-op.
Yeah, as per our guidelines, aspirin is all right. We can do deep blocks and also neuraxial blocks in a patient who is on aspirin. Can I take one last comment from the panelists?
Regarding the aspirin, except in intracranial and retroorbital surgeries, aspirin can be continued even as per the American Society of Anesthesia regional guidelines. And it is also it can cover the perioperative antiplatelet therapy as well. The first point, what Dr. TVS sir has nicely narrated, the focus, that is a point of altercate, understanding by the anesthesiologist and surgeon on before surgery is very important in these set of cases. If you can do a focus, if you know the diameter of IVC, that tells whether the volume is depleted or volume loaded. So you can always control the volume therapy. And there are multiple data and multiple studies have said these Vimeda, that is valsartan and AR2 blockers. Presently there are different opinions among the top 2 cardiologists. Some people say please continue, some people say withhold. So as an anesthesiologist, if the volume is good, if it adequately fill volume, if the patient doesn't have any symptomatic issues, I think we'll go ahead and do the AR2s and valsartan and sacubitril, because these are institutional practices.
I'm sorry, sir. We have a dental surgeon on stage.
Please.
I have to ask you one question. If a patient came to you for a root canal or a tooth extraction and is on aspirin, would you advise that it be stopped, or are you okay to continue?
Our old practice is to stop for at least 3 to 5 days and then do the extraction, sir. But recent guidelines, we don't need to stop. And for the root canals, any other procedures, we don't need to stop aspirin or any aspirin.
So aspirin, it is okay to continue?
It's okay, sir.
So thank you very much, all of you. I'm glad we've ended the session with 10 minutes to go. We move on to the much awaited session of the day. I request the organizers to take over.
We request Gopal sir to please stay on the dais, and our panelists also please stay on the dais. Thank you everyone for your valuable inputs on various case scenarios. Now I call upon the dais our beloved Managing Director and Chief Cardiologist, Dr. Ramesh Babu sir, to felicitate Dr. Gopal sir.
లైట్లు ఏదా అయింది చేంజ్ లైట్లు కూడా ఉండదు అయి సార్ గురు
Thank you, sir. Thank you.
మా ఇక్కడ పోలీస్ స్టేషన్ అయిపోయింది ఇవన్నీ అయిపోయినాయి మా ఫోటోలు జరిగింది.
Now next, the most awaited session, the guest lecture. And for the panelists for this session are Dr. L. Ramchandra Garu, Senior Consultant Physician, Ongole.
Dr. V. Krishnamurthy Garu, Senior Consultant Physician, Vizag.
And Dr. S. Sudhakar Garu, Senior Consultant Cardiologist, Praja Vaidyasala, Vijayawada.
Dr. P. Prem Kumar Garu, Consultant Cardiologist, Apollo Hospital, Kakinada.
Now the speaker for this guest lecture is Dr. B. Somraj Garu. Please come on to the stage. And dear doctors, it is my great honor to welcome Professor B. Somraj Garu, the doyen of cardiology in India. And Professor B. Somraj Garu needs no introduction. He has been a guiding force in the field of cardiology. He completed his MD from Guntur Medical College and obtained DM in cardiology from prestigious PGIMR Chandigarh in 1978. He held many key academic roles, including professor and HOD of cardiology at NIMS and later as Dean. Under his mentorship, a whole generation of cardiologists have been trained and gone to achieve great success. He has published over 120 papers in various international journals, including multiple prospective randomized control trials. His book, Clinical Methods in Cardiology, is essential reading for all the cardiologists, and he also authored a chapter on rheumatic fever in Braunwald's chest diseases. He is also famous for research, especially collaborating with our beloved President, late APJ Abdul Kalam Garu, which led to the creation of first made in India stent, that is Kalam Raju stent. He has been awarded Padma Shri in 2001 by Government of India, among many other awards. Ladies and gentlemen, please give a big applause to Dr. Somraj Garu. Thank you.
Morning to you all. Thank you very much, and thank you Dr. Ramesh and his colleagues for making this occasion possible and share with you some of my thoughts. You can see in the program, my lecture is called guest lecture. They didn't mention the topic. The reason why they don't mention the topic is when somebody is going to say something that should not be said. Somebody is going to talk something that should not be talked about. Generally, it's presented like that. But while we may go through this, if I fail to complete what I wanted to complete, what I want us to just go through and bring out what I wanted to say will be in this slide. Namely, some of them I just read out. If I fail to complete the lecture, these are the things that I wanted to communicate. That you can see that for the present day practice of medicine, when you look at from 96 when Ramesh started here, and earlier we started somewhere else, many of you started even earlier, we were hardly able to do lot of things we do today those days. Lot of patients we were not able to diagnose, lot of patients we were not able to offer things that can be offered today. So much can be done today by way of diagnosis as well as treatment to a variety of disorders. There is hardly any disease that can't be treated today, though not cured. But we are typically in a situation of doing more and feeling worse. At least some of us realize it. Can anything be done to change this in the present situation of medicine? So I will just read out. The answer to some of that can be, we need to have doctors without hospital, regional and national borders. The name of this conference is Fusion. It's rightly done by Dr. Ramesh. How we can bring together the best minds in medicine, the best techniques in medicine, best technologists in medicine, and best experts, physicians, surgeons, and everybody together, so that we can deliver better things to the populations that we serve. And the importance of generalists today, wider knowledge of medicine, not just a narrow specialization. It's called polymathism in medicine. We need to have a generalizing specialist. In other words, if you are a specialist, whether you are a cardiologist or an endocrinologist or anyone, don't lose that touch with internal medicine. Same thing applies to surgical specialty. Should we bring back the honorary system in hospitals and colleges so that the best minds are available to students and the patients? Doctors to take over medicine in all dimensions, not only just management of disease, but also management of healthcare. Medicine is a social science, and politics is not more than medicine on a grand scale, as Rodolfo Ochoa said. Redefining retirement. When you see the speakers in this conference, most of them are about to retire or should not have continued, they should have retired just like me. But then, can they contribute? Is it time to redefine retirement so that we can contribute to organizations, people and students and then juniors? And the importance of second opinion. The artificial intelligence and as an expert consultant, not replace you as a doctor. Just like we take our second opinion in most of the situations, use artificial intelligence as an expert second consult. And public education and lifestyle modification so that we have primordial prevention as our aim, not just tertiary prevention. And be political. Don't keep away from politics. Those of you who can do it, join politics in different forms. This is what I want to convey. But then, if time permits, I will be able to complete some of that, and I will just say, when you do more and feel worse, and there is a progressive overall, most of us agree that there is a progressive loss of trust in medicine across the world. Not only in this country, across the world. We do more, but people seem to be trusting us less. The reasons may be many. So it's called causes of causes. There is a burnout and emotional exhaustion, loss of physician autonomy, bureaucracy and paperwork has increased. Corporate control of healthcare is a serious problem now. Public distrust, over-reliance on technology, debt burden and after education. Those of us who are specialists who know that by the time you finish it is more than 15 years. And by that time one is married and have one or two children, and then you are looking for a job. And when you get into a job, what happens, I must tell you, and you don't have enough financial resources, some of you may be in debt, and then present situation doesn't help it. And then you are forced to do things that you don't want to do. Fear of litigation and defensive medicine. Medicine has become a commodity, and loss of professional autonomy is a feature now. I won't go into minor details except bring out these major issues. Technological disruption without ethical integration, hyper-specialization and fragmentation. We have super specialization today to the extent we have not only organ specialists, but in the same organ, multiple specialists. Even in cardiology, we have a variety of specialists in cardiology, electrophysiologists, general cardiologists, and then heart failure specialists, echocardiographers, and then even in heart failure subspecialists. So that narrowness of specialization is creating problems also. And dysfunctional medical education in the pipeline. So medical education, what we went through our times was, the requirement was biological science and clinical science. But with advances in technology and molecular biology, information technology, artificial intelligence, etc., those two branches are no longer enough. We need to have wider knowledge of physics, chemistry, information technology, social sciences, teamwork, leadership, and everything. So medical education has to be redefined. And regulatory overload and policy culture. The politicians and bureaucracies, their entry into medicine and their controlling medicine has become commonplace. What side effects it produces is everybody's experience now. Public perception should consumerism in healthcare, and the public also have something to worry about. Cultural devaluation of expertise, moral injury beyond burnout, lack of unified physician voice. We don't come together to bring out these issues and make differences. We should come together and see something, and I have hope that what Dr. Ramesh did in calling this a fusion, I think we should take this forward. So in summary, there is systemic collapse, decline driven by loss of purpose, autonomy, ethics and trust. Unless causes of causes are addressed, superficial reforms will fail to restore the public trust we badly require in medicine. I will skip some of this. Our physician culture. The physician culture is brought to us from our medical education. In our medical education, we were taught well most of the time about medicine and related issues, but we are hardly taught about how to manage ourselves. Management skills, leadership skills, teamwork is never taught. And we are never taught about other scientific requirements that are required of medicine. So medical education has to be redefined. I will be only bring out only some of the issues. If I have time, we will have some discussion later. Okay. And the decline of medicine is significantly contributed to by politicians. So in the name of, say, whether it is healthcare provided by governments today, in the name of, say, Arogyasrees, etc., and tertiary care is directly addressed. Hardly anything is done in primary care or prevention. And that's because that brings the votes. So it is prioritization of profit over public good, fragmentation of healthcare systems, politicization of health and science, short-termism election cycles. What gets me votes in the next election, I will want to do. There is some change in the way the governments are doing now. The central government came out with the models of providing total, say, social determinants of health, trying to address, but more requires to be done. Underfunding public health infrastructure, commodification of corporatization of healthcare, erosion of professional autonomy, deepening inequities. Healthcare becomes a privilege for the wealthy, marginalized groups face systemic neglect, encouraging cynicism and distrust, failure to protect medicine's moral mission. So, having said this, I just want us medicine and politics. I thought I should just bring out some of this. So, Alexis Carrel, around 1940s, is a vascular surgeon. And you know what he said? He wrote a very great book called Man the Unknown. He said medicine is the super science of humans, man. And Adolf Virchow, the father of pathology from Berlin, Germany in 1848, he said medicine is a social science, politics is nothing more than medicine on a grand scale. Then, if you just extend his concept, medicine is a social science, politics is nothing more than medicine on a grand scale. Medicine being the super science of humans must enter politics and guide world leadership. Politics and national leadership are too important to be left alone to politicians. Polymaths from different fields. Polymaths means people with generalized knowledge must step into the political sphere. The way the world leaders are managing the global affairs makes this even more urgent today. So that way we will be able to regain the trust that we lost in medicine. Doctors should enter rule-making bodies in the country, and we find everybody is every other area. People are just I won't mention the areas. Many of them enter into Rajya Sabhas and assemblies, but there is hardly any facility for doctors to enter. So it's time that you people should do that. And this is more for youngsters now. And then this is what we need to do. So I finished here. If you have any questions or suggestions, feel free. Thank you.
Thank you very much, sir, for your valuable words. Please stay back on the stage.
Hello, I am Dr. Sudhakar from Vijayawada. సోమరాజు గారు చెప్పినంతా అందరికీ బాగానే అర్థమైంది అనుకుంటాను. నేను నా ప్రాక్టీస్లో ఎన్కౌంటర్ చేసిన యానిక్డోట్స్ చెప్తాను మీకు. ఒక పేషెంట్, షీ ఈజ్ ఓన్లీ 23-year-old ఇంజనీరింగ్ స్టూడెంట్. షీ కేమ్ విత్ I took a chest X-ray and there was a mediastinal mass which was compressing the nerves and causing pain. So the lack of trust in the general practitioners is the main cause of the problem. For everything they go to a specialist. If it is a headache, they go to a neurologist and they take CT and all. Even if the headache is accompanied by fever, they take a CT. Even just dehydration can cause headache, and fever always has headache as a component. So we should, patients they want to go to a specialist. Gastroenterologist is basically a physician. After completing MD only he goes to gastroenterology. He could have taken chest X-ray in the beginning itself. So we tend to do more investigations, that too more costly investigation than basic investigations, and we stop seeing the patient as a whole, where as Samaraj చెప్పినట్టు we are not doing holistic medicine, where ఇంకా సూక్ష్మ ఇంకా మైక్రోస్కోప్ ఇన్వెస్టిగేట్ చేస్తున్నాం. కంపాషన్ ఈజ్ ది మెయిన్ థింగ్. ఫస్ట్ అసలు నేను చాలా మంది దగ్గర కార్డియాలజిస్ట్ దగ్గర చూశాను. దే ఆర్ treating seeing the BP themselves as unliquefied. They are not taking the pulse, they are not taking the history. Somebody else is taking the history and they are not examining the patient properly. Thank you.
Thank you, Dr. Samraj. This is entirely different topic, not from routine cardiology, what he has been teaching for decades together. And I agree with all or most of it. And I was talking to some of the people. The mistrust is the greatest issue in the society with regard to the medical profession. The distrust is not only in the society but amongst the medical colleagues themselves. And the reasons, for example, if you take cardiology, so many variables are there, so many confounding variables are there, and so many types of presentation are there. Likewise, for headache, if there are 100 causes, and as part of the defensive medicine, neurologists or physicians, we are prescribing CT scan if we feel that, there is 5% chance or even 2% chance that he may have a brain tumor. And it is not possible physically to examine and to rule out or rule in. I was just talking to some of the doctors who have turned out to be politicians also the other day. He was also bringing the same point. Mistrust is a major factor. He is a very, very seasoned and very knowledgeable doctor and politician. The only way I can see, sir, it's not possible probably for all the cardiologists to check the blood pressure whenever the patients come, because now you have definitely more machines which are with automation, and the measurement, of course, has got a lot of variables also. Now, when we are practicing defensive medicine and we cannot exclude 100%, and when the litigation is so much, is becoming more and more now as part of the defensive practice, the only way probably which I think is a robust clinical decision support system, which is definitely evolving now. And the patients, now they have started feeding themselves the data, the symptoms into Google, and then they come with their differential diagnosis. It's all, we think that they are overdoing the things, but it is actually protecting ourselves. Because they know they come with headache, it itself tells it is 5% chance that you may have a brain tumor. So he will decide whether to go for a CT scan spending 3,000, 4,000 rupees rather than blaming the doctor if it turns out to be negative. That is what has been happening. The other, of course, in the cardiology, the causes of mistrust are many because of the uncertainty, gaps in knowledge, which I will be trying to cover in the topic which I will be talking. And once you have a system which is a global, which is accepted by medical societies, and if the person feels that he has 5% chance, I want to exclude, he will spend comfortably 3,000 rupees or 4,000 rupees and exclude. So the blame game on the doctors is mainly on the cost. Though they know that doctor has done with good intention, but if it turns out to be negative, then if the doctor could have spent more time and then ruled out clinically rather than advising this investigation. So likewise, probably the AI, whatever is happening, the quantum computing, where the multiple prediction models with definitely more precision in times to come than the most experienced physicians, radiologists and all, the medical imaging, everything is coming up now. So AI is definitely going to help not only the patients and the healthcare, but also protect the medical profession. I think because of the shortage of time and the shortage of the personnel available, every super specialist should be effectively utilizing the time in giving the best to the society and covering more number of people who really require this. So this is where I end, and thank you so much, sir, for accepting.
My name is Dr. Prasad Rao. I would like to comment on Dr. Somraju. I know him for the last more than 50 years. Even though he said the politics and medicine are inseparable and we get into politics, Dr. Somraju has been the cardiologist for many important people, not only in Andhra Pradesh but also in all over the country, including N.T. Ramarao, Abdul Kalam, Rajshekhar Reddy, everybody who happens to be. I would like to mention here, Dr. Somraj utilized this opportunity to develop medical institutions, be it Usmania Medical College, his starting institution in Andhra Pradesh, Nizam's Institute of Medical Sciences, the present form of Nizam's Institute of Medical Sciences was started by his advice and Dr. Kakal Subbarao's directorship, made into the university in 1989. That was a landmark achievement which is responsible for several students, several education opportunities, new technologies, research projects coming up in Andhra Pradesh and also in several parts of the country. In addition to that, he also utilized the opportunity of his association with Abdul Kalam to develop this tent. After developing the Nizam's Institute of Medical Sciences, both through his individual effort as a professional cardiac professional, very big cardiac professional, and also as a leader for developing the institutions, he went and started this quality care, which is the present care group of hospitals, which is itself is doing very well. This is one way. Dr. Somraju has not become the politician. He would have gone into Raj Sabha, any Sabha which is present, but he utilized this opportunity to develop the medical institutions, develop the students, teaching and other things. This is also one model which every one of us have to understand. Thank you very much for giving the time.
Hello, I am Dr. Ramchandra Rao, physician practicing in Ongole for the past 48 years. I was associated with what he used to tell us. Treating the disease is only half of the problem, and managing the patient, managing the attendants, talking to them, spending time with the patient, that is equally important and more important than just treating the disease. And if you do that, all these litigations and all these consumer problems would be much, much less than what would be if you spend. Thank you.
Thank you, one and all. Now I request Dr. Somraju Garu to come on to the dais and Dr. PRB sir to felicitate Dr. Somraju Garu. Thank you.
వసనా రైట్ ఆయన సైడ్ సాయి వినయ్ ఆయన పట్టుకుని ఆయన గ్రీన్ టీ షర్ట్ వెనక్ సైడ్
To the dais and give away the mementos to panelists.
స్క్రీన్ కనిపిస్తా ఉంటుంది.
Now we move on to the next topic on vascular and valvular interventions, and the panelists for this session are Dr. Maulali Garu, Senior Interventional Radiologist, Guntur. Dr. K. Srinivas Reddy Garu, Consultant Cardiologist, Karmuri Hospital, Guntur.
Dr. N. Murli Krishna Garu, Consultant Cardiologist, Manipal Hospital, Vijayawada. Dr. Purnanand Garu, Consultant Cardiologist, Purna Heart Institute, Vijayawada. Dr. N. Kiran, Vascular Surgeon, Kiran Vascular Center, Vijayawada.
Dr. Peddeswara Rao Garu, P. Chief Interventional Cardiologist, Peddeswara Healthcare Center, Vijayawada.
Dr. P. Raghuram, Consultant Cardiologist, Ayush Hospital, Vijayawada.
And Dr. G. Ramakrishna, Consultant Cardiologist, Hyderabad.
Dr. T. Karthik, Consultant Cardiologist, ABC Heartcare, Vijayawada.
And Dr. R. Maruti Varaprasad, Cardiothoracic Surgeon, Komineni Hospital, Vijayawada.
Dr. Prashant P. Prabhu, Cardiothoracic Surgeon, Sunrise Hospital and Heart Institute, Vijayawada.
And Dr. Vishwanath Karthik, Sunrise Hospital and Cardiologist, Karthik Hospital, Vijayawada. Thank you.
I would like to invite Dr. Naga Sandeep Garu, cardiologist from Manipal Hospital. Now I would like to invite Dr. P.C. Gupta, who is a clinical director and head vascular and endovascular surgery, Care Hospital, Hyderabad. He pursued his medical education at AFMC Pune, PGI Chandigarh, Nagoya University, Japan, Baylor School of Medicine, USA. He is the president of Vascular Society of India and vice president of World Federation of Vascular Societies.
Good morning everyone while the system is being set up. It's a pleasure to be here in Vijayawada this morning and thank you Dr. Ramesh for the invitation. It's very nice to be amongst this galaxy of stars of cardiology and cardiac surgery here. And I'm going to talk about something which is okay, thank you. So I'm going to talk about carotid intervention, something we started doing actually with cardiology support in care hospitals. So we started with, along with CABGs and then took over symptomatic carotids. So I'm going to talk about what is the intervention that should be done for patients who are symptomatic. So extracranial carotid disease is an important cause of stroke. It's a cause of stroke in about 10 to 15% of patients who are admitted to neurology. And carotid endarterectomy in symptomatic patients can reduce risk of further disabling stroke. It can be done safely in this group of patients, and it is best done within 14 days of the index event. And if you look at the earlier landmark trials which compared best medical therapy with best medical therapy and CA, we find that there is a significant reduction in stroke, both the trials, the NASIT and the ECST. Now, what are the stroke prevention strategies? When patients come with stroke and carotid artery disease, we revascularize the carotid. We control the blood pressure, good glycemic control, cessation of tobacco use, reduction of cholesterol, and especially there's a lot of focus on LDL now, and of course antiplatelet therapy. So what are the options? Carotid endarterectomy, carotid artery stenting, and now of course TCAR, which is not available to us, which is transcarotid revascularization. My choice of the procedure is carotid endarterectomy. When would I think of carotid artery stenting? If it's a very high lesion and surgically it is very challenging to get there and causes a lot of risk. Recurrent stenosis, irradiated necks, these are sort of relative indications to go in for carotid artery stenting. They are still good candidates for open surgery. If there is a contralateral recurrent laryngeal palsy, I would be concerned and might opt for stenting. And of course, if there is a high cardiac risk. So these are some examples I wanted to show. We published this endarterectomy in hostile neck. So this is a patient who's actually had a myocutaneous flap after radical neck dissection, has had radiotherapy for cancer treatment, and then we have done the endarterectomy because he was symptomatic. Another patient who's had a radical leg dissection, and then we've done carotid endarterectomy, and we came out quite well in these patients. Now, if we look at the guidelines coming from the European Society for Vascular Surgery and the Society for Vascular Surgery, most of the class 1 level A evidences favor carotid endarterectomy when there is a stenosis of 70 to 99 or even more than 50%. The role of probably carotid artery stenting, it could be considered in patients who are relatively younger and within the first 6 months, but not in the first 14 days. So if we are looking at acute stroke or acute symptoms and planning intervention, carotid endarterectomy is the procedure of choice. Now, if we look at 20-day stroke and death rate in symptomatic patients in various trials comparing stenting versus CEA, and it's very, very clear that carotid endarterectomy has a much lower complication rate compared to carotid artery stenting. And in fact, in Care Hospital, when I was working, the chief of neurology would initially not refer cases to me, telling me that they preferred stenting and not surgery. And it's after all these trials came in that they shifted completely, that we practice evidence-based medicine, and I started getting all the referrals from neurology for endarterectomy. And of course, there are, if we look at various trials and compare them, again, if we see best medical therapy versus CE and best medical therapy, we find a higher risk of stroke complications on best medical therapy compared to endarterectomy. Similarly, when we look at carotid artery stenting versus endarterectomy, again we find a significant difference and a much lower complication rate and death rate in patients who undergo endarterectomy compared to stenting. And this is a meta-analysis of trials which enrolled a large number of patients, more than 500, and we see similar results in these trials. So what is the protocol that we follow? All stroke patients are evaluated by a neurologist. We start them on dual antiplatelets before surgery. Of course, start them on statin. Longitudinal arteriotomy we repair with a patch. And then post-op again, patient is evaluated by a neurologist. These are some of the examples of ultrasound where you can